And Brahm Goldenberg, yes, is a supervisor at the Children's Aid Society of Toronto, and has worked at the center for the past 14 years and has worked in a number of positions. And Franz Noritz is a supervisor at the Children's Aid Society of Toronto and also has worked for 20 years. So again, we see an incredible wealth of experience and expertise. Come on up.
Because we're working in pairs, we've designed the presentation a bit different than we were doing it all on our own. So we're working in partnership here.
So actually, the timing was actually very perfect. It's almost as if we connected with each other before we came here today, because the last note of your slide speaks to the impact of parental mental illness and substance abuse have on kids. So it's a very good segue for the two of us today. So again, thanks everybody for coming here today and for showing your interest in our project. My name is Brahm, and this is Franz, and we're both supervisors at Children's Aid in Toronto. The agency we work at is the largest board-operated child welfare agency in North America. Toronto is the largest and most diverse city in Canada. There's about 2.5 million residents, and in 2013, our agency served over 11,000 families and 24,000 children. So our everyday responsibility as supervisors is to manage a team of child protection staff who work with children in need of protection and their families. And for years, we recognized the challenges that our field encounter in providing services to parents who have suspected or diagnosed mental illness. In response to that, we developed a project idea to better help these families. And after a few years, we're proud to say that we now have a collaboration with a local mental health agency. Today, we're here to talk about our Healthy Families project and what we hope to accomplish. So the learning objectives, we actually have 3 learning objectives that we want to make note of. First, we want to talk about what we've come to understand are the challenges for our sector in working with this group of families, particularly in a city quite as diverse as Toronto. And the second, the benefit with meeting a senior adolescent within the healthcare system rather than politicians in order to get our project off the ground. We thought start small with the potential for big change. And third, we'd like to talk about how we went about promoting our idea with community mental health agencies who already have very, very busy services. So by way of background, we know that everyone here today fully appreciates how the child welfare and adult mental health sectors have traditionally worked in silos and the many problems that come from it. So let's just start by showing you a little data about our families we serve. While our agency has many branches throughout the city, at our particular branch, at any given time, we serve between 700 to 750 families. What may be surprising to hear is that when we reviewed our files, the 700 files that we reviewed, we found that in 43% of those files, there was a parent with a diagnosed or suspected mental illness. And of these parents who have a suspected or diagnosed mental illness, only half of those are actually connected with any service at all. And that was really upsetting for us to learn. We also looked more closely at the number of children living apart from their parents, those that are in care. So we found a very great concern to us. 45% of the 175 kids in our foster care system have a parent with a suspected or diagnosed mental illness. We also found that 57% of the children living with kin have a parent with a suspected or diagnosed mental illness. Let's talk a little bit about the challenges that we found from our staff. And at the time of our file review, Franz and I surveyed our staff about their experiences in helping their clients navigate the mental health system. And this is what they've told us. First, there's a long waiting list for parents who are motivated to get help. Second was there was insufficient cultural and language-specific services available in Toronto. Third, frustration in working with professionals in the mental health system. So some of the examples that we heard about is parents when they're discharged from hospital with seemingly no aftercare plan, or parents who weren't admitted to the hospital at all. Lack of in-home services. And then parents who won't or can't accept they have a mental illness. And our own staff's lack of knowledge in discerning between a parent's behavior, mental health, substance misuse, settlement issues, or just anger towards their child welfare worker. So I wanted to talk a little bit about the competing mandates between the child welfare and the adult mental health sector that we learned about. Very early on, Franz and I read through literature from the US, Canada, UK, and Australia to learn about how the adult mental health and child welfare sectors can work together to address the shared needs of our clients. Instead, what we found was a multitude of studies that outlined the challenges these sectors experienced when they intersected with one another. There were also some reports that talked about systemic reviews that were undertaken after a child or parent death involving a mentally ill parent. With these reviews came many recommendations that details how the two sectors really did need to work together. Unfortunately, despite all these papers and these reviews, systemic change is still very, very slow. We've submitted our syllabus, and in the first 2 pages there's some references regarding articles on this topic. Next is the impact on child safety. So many families come to the attention of child welfare from first responders after a parent experiences a mental health crisis and they're no longer able to care for their child or children. However, in far more situations, parents who have poor mental health become involved with the child welfare agency because they have difficulty meeting the needs of their children, whether that be emotional, social, developmental, or their physical needs. Out of our strong wish to better provide service to our clients, we were motivated and inspired to do something differently. We researched several models of service to inform our project idea. So the first, we looked at staff training. We thought, perhaps we just need to train all our staff differently on mental health issues and how to work effectively within the mental health sector. Second, we considered developing a specialized team from our own staff complement who would only work with this group of families. Third, we find a pool of money somewhere and we pay for expedited service where the clients are at most high need. Another option which we considered was to contract with a psychiatrist or some other mental health professional or expert to provide case consultation to our staff. And the last model, the integrated service team, is what we decided to pursue. We envisioned a group of staff from an adult mental health agency working within our branch who would only serve our clients. We found a partner with the Canadian Mental Health Association who shared this vision. Then it became time to get money. Once we actually had a clear project idea to fund it, and we really had 3 different options to look at. The first is the Ministry of Child and Family Services. We actually decided not to look there because our own ministry, they're under extreme financial pressures to contain rising child welfare costs. Another option was to look at grants from foundations. So at our agency, when we launch other projects, we often apply to foundations for special grants. We decided not to go that way because we were told grants are small in financial monies and also short-term in nature. Then we got some advice from one of our colleagues that recommended that we contact someone within our regional office of the Ministry of Health. We know this ministry is always looking to ways to improve the way healthcare services are delivered. So in Ontario, 14 what's called local health integration networks, or LHINs, are the only organizations in Ontario that bring together healthcare partners to develop innovative collaborative solutions. The goal of doing this is to provide timely access to high quality services for the people of Ontario. They ultimately decide what programs get funded and what don't. To be honest, one of the real reasons why we went to them is they have a much larger pool of money. So why the T-ceiling? We knew that arranging a meeting with someone or a group of people at a senior level at the Ministry of Health, or even a politician, would be extremely difficult, if not impossible, for just the two of us. Instead, we reached out to one of the analysts at the local bank, the Toronto Central Bank. After the analyst heard a little bit about our project idea, she invited us to a meeting where we convinced her why our project would be relevant and benefit for their funding. So the first is from their strategic plan. The LHINs need to see better, coordinated, more accessible, and more effective healthcare. Second, in Ontario, several studies have been commissioned to address the problem of inappropriate use of our ERs and the high financial costs associated with that. Third, the healthcare system recognizes there are significant gaps for many patients who actually leave the hospital. And finally, many people in Ontario do not have a family doctor. Fifth, some children and youth who are raised by these parents, as we've heard lots about in our conference in the last few days, who are raised by these parents, years later require services from the adult mental health system themselves. And sixth, many of our clients are poor, undereducated, live in substandard housing in poor neighborhoods, and are often quite isolated. And all these factors are part of the social determinants of health. So Franz is going to talk about securing our partnership.
Well, what was exciting for us is once the Toronto Central LHIN actually expressed an interest in our project, we were able to secure a partnership with the Canadian Mental Health Association, which is an adult mental health organization across Canada. Now, initially our journey to secure an adult mental health agency to collaborate with us was a bit discouraging. We had looked at different agencies within Toronto to see who would be able to collaborate with us. Many of the organizations in Toronto don't actually provide in-home service to clients that they serve. We saw this as a fundamental problem because our clients tell us that in-home service is the most effective for this population. In addition, the way organizations are funded did not allow for an exclusive collaboration with child welfare. While some other organizations do not have enough expertise in working with parents or children, we learned that about 2 of the organizations that do provide mental health services to clients in their home, and one of them was the Canadian Mental Health Association. The other organization who we were also interested in partnering were in the middle of restructuring and were not able to partner with us. So the Canadian Mental Health Association understood the challenges and of our clients and staff in navigating the adult mental health sector. CMHA Toronto branch also appreciated the impact that parental mental health had on family functioning. And for these reasons, we knew the appropriate agency to collaborate was CMHA. Together, we believed the best practice model was to set up a multidisciplinary team, case management, which would be located at our actual work site. Shortly thereafter, we put together a business proposal, which was accepted by the Toronto Central LHIN. We received funding to operate our project for 15 months. The next step was to hire 2 social workers, 1 occupational therapist, and 1 mental health nurse. Now, in terms of program design, the focus is really to provide assessment and short-term intervention for families. This would most likely be between 3 to 6 contacts, and those parents who require longer-term support would be linked to community services already existing. We also wanted to make sure our program was made available to as many families as possible with longer-term case management. Now, the team is also responsible to connect parents to primary care as well as other health services. Parents who have family doctor will more likely receive better care of their physical and mental health. Now, the families will also be provided with psychoeducational support in order to decrease the stigma and increase their knowledge of mental health. The team will also be offering training and case consultation to our own staff at our agency to improve our own capacity. The primary objective of our Healthy Families program is to improve parents' mental health. Second, we want our parents to have easy access to service. We recognize that there are a number of barriers in securing appropriate interventions for the parents that we serve, specifically long wait lists, lack of language and cultural appropriate interventions, and scarce in-home service. Now that the team sits at our actual work sites, families get supported to get connected to support quite quickly. The third objective is to improve access. As we pointed out earlier, the only professional involved in the large number of families we work with is their child welfare worker. When we reviewed our cases in our branch in 2012, you'll remember that only half of the parents with an identified or suspected mental illness were connected with any professional support. In addition, we learned that many of these parents also did not have a family doctor. As such, they were not receiving effective mental and physical health care management. This then in turn leads us to our fourth objective, which is to decrease the reliance on parents' inappropriate use of emergency departments. Another objective relates to the team's practice philosophy, which is to start with the client is at. They are practicing from a health and wellness perspective based on the social determinants of health. This means working with the family around what they identify as their need, such as, do you have enough money to pay rent, or do you have enough food to eat, rather than only looking at their mental health. Given our client population, we have a number of unmet needs. This approach really made sense. The next objective is in line with the mandate of child welfare, which is to keep children safe and whenever possible, keep families together. Again, you will recall our branch reviewed about 45% of children in foster care, as well as 56% of children who are living in kin have a parent with identified or suspected mental illness. Our goal is to change that. Lastly, we want to help families recognize the impact poor mental health can have on the family relationships and parenting. Program evaluation. Well, given our Healthy Families program is unique to child welfare in Canada, we understood the importance of evaluation. Fortunately, we were able to allocate a small pool of money directly towards this evaluation. We decided to focus the research on 5 key areas. First is the family program meeting the objectives. We need to demonstrate to our funder that their dollars are being spent effectively. Second, what are the emerging characteristics, trends, and short-term outcomes of parents who are involved in our Healthy Families program? Third, are there any differences between parents and children who receive services from our Healthy Families program in comparison of those who don't? Fourth, increased capacity of child welfare staff. What, if any, impact does our Healthy Families program have on our child welfare staff regarding their practice and service within their families? And last, impact on service provision, coordination, and collaboration between the two sectors. What we mean here is to understand the extent of how our program has on the working relationship and service coordination between the staff and the mental health services that our clients are involved with. Case example. Now, the Healthy Families project has now been running for just the past 2 months. The CMHA team began working with their first group of families. We wanted to share with you a story of one family to illustrate the impact of the program. Mr. A is a 62-year-old father, single, to Sally, age 17, and son, age 15. A referral came to child welfare in February of 2012 due to concerns with dad's depression and poor parenting. Also, Sally's defiant behavior and Nick's poor school attendance. Now, currently, Mr. A resides in a subsidized 3-bedroom apartment in downtown Toronto with his children. Now, he separated from his children's mother, Mrs. A, several years ago after his wife seriously assaulted him. In addition to the child protection concerns initially identified, the family is under serious financial difficulties. The family's only source of income is Mr. A's government disability check, which is wholly inadequate to meet the needs of the family. Further, Mr. A has outstanding debts from the matrimonial home prior to his divorce, which has led to his bank threatening legal action against him. The children do not seem to understand the family situation and still demand that the father pays for their cell phones. Now, it is important to note that the reason why Mr. A cannot work, in 2004, he underwent heart transplant surgery. Since that time is required extensive ongoing medical follow-up, which can often involve admissions to hospital for days at a time. From the time Mr. A started caring for his children on his own, he had a number of hospitalizations. In each instant, he had discharged himself early, worried, and not wanting to leave his children alone. Mr. A also has been diagnosed with type 2 diabetes and hypertension. Probably thinking, boy, this guy has a lot of problems. Mr. A, he also doesn't eat consistently or take his medication as prescribed. As a result, he often feels weak and has actually fallen a number of times in his home, causing him physical injury. In the last few months, he's not been able to leave his home for medical appointments because he's too frail. He's reported feeling overwhelmed, depressed, and guilty for not being able to be a parent that he can be to his children. Meanwhile, Nick has not been going to school, plays video games all day, criticizes his father for being a bad parent, steals money from him, and invites his friends over, and they end up eating all their food. Sally spends a lot of time out of the home. She drives her father's car without permission and does not provide support with the household chores. Now, the child welfare worker involved with this family has made many efforts to help the family, but unfortunately, all of the efforts have not facilitated any meaningful change. One example relates to Mr. A's depression. The child welfare worker had referred him to a psychiatrist at the local hospital. However, because of Mr. A's frail condition, he's not been able to get to the appointment. Unfortunately, the child welfare worker did not appreciate the reason for Mr. A's lack of follow-through to the psychiatrist. This in turn led to some animosity between the father and his child welfare worker, and he's been left feeling unsupported. Now, the worker made it clear to Mr. A that if you don't seek treatment, the agency would be considering moving the children from his care. As you can imagine, it's only worse than Mr. A's depression. Now, the child welfare worker and his supervisor knew that their intervention was not being very helpful and wanted to keep the family intact. They believed that Mr. A's mobility issues, that in-home mental health services would make a big difference, but sadly, none were available. Now, the timing was right, as our program had just begun. The child welfare worker made a referral to the Healthy Families Project, and Mr. A was assigned an occupational therapist. During their initial home visit, the OT undertook a functional assessment of Mr. A's and his living environment. It became evident that there were many physical hazards in the home which contributed to his poor health. For example, the OT recognized that the staircase outside the home Mr. A could not navigate, and it caused him to be virtually a shut-in. After the assessment was complete, she and the team took coordinated action. They drove Mr. A to the hospital for an evaluation. They facilitated a referral to an elder care clinic at the local hospital. They provided safety equipment for the home to prevent Mr. A from further falls. They also connected the family with Community Care and Access, which is an agency who provides practical home support. Mr. A was also given information about a more affordable transportation service to take him to his appointments. We also advocated for service for Mr. A to see a specialist in internal medicine. They also reviewed his medication and placed them in blister packs to make his medication compliance easier. Along with the child welfare worker, they also jump-started a transfer to more suitable housing. From this experience, the child worker learned the impact of Mr. A's physical health on his mental health and parenting. With the new appreciation, he was able to provide better service to the family. 3 weeks later, we've already seen a small change within this family. While there's more work to be done, we believe this program has changed the trajectory of this family. Mr. A now has a family doctor. And with the new transportation, we hope that he's going to be able to get to his appointments. We've seen a little bit of improvement in his physical health. He also seems a bit less tired. The children have also received some psychoeducation from the social worker of the team, and now start to slowly appreciate the situation their father's in. The child welfare worker and Mr. A now understand what the actual needs are for this family, and now they can start working at addressing some of the parenting issues that we see. The child welfare worker also understood that ill physical health had an impact on his mental health, and that then made his physical health even worse. Now, typically, the profile of this family is not typical. Often, as you probably know, meet more single mothers, those mothers who are just lack of support in the community. But this was one example that came to us that we thought really could talk about both the physical and mental health impact that our team can actually have on some of our clients.
You're all hungry, but if you have any questions? I actually have a question in terms of why you decided on the composition of the staff of the team, the OT, the nurse. I'm sure that was a very active conversation in terms of expertise.
It was actually the Canadian Mental Health Association who had that idea. They understood and realized that the needs of families are quite complex, and it's just not focused around mental illness, but it's also just around other unmet medical needs and physical needs as well. So an OT, a nurse, people have different areas of expertise that can really contribute and provide assistance to the family.
They were already doing some work in the community. Their practice philosophy, at least this branch of CPG, is to have a very much a multidisciplinary team.
Any other questions?